Yeah. It's off mute. It's off mute. I've got speaker and I've got video.
And I'm unmuted. Can you hear me through your PC?
A little bit.
Okay, I got it down low because I didn't want it echoing. How's that? Okay, now I can hear you. You took your earphones off.
Okay.
When you had them on, I couldn't hear you.
Okay.
I don't know why.
Let me turn them all the way off.
Yeah, that was the difference. Hi, Brother Olaby. We have set up the live stream, so it's going to start at, well, it has started on the live stream, but we're going to give people the, the time to get on at 3. He's not there. He was there a minute ago. Okay, you guys, we're going to be starting in about 10 minutes. It's 2:50. We're going to allow everybody to get on. So be comfortable. Brother Olaby, if you'll can you take care of the waiting room or not?
Who's phone number 510?
I don't know. Who's that on the phone? You want to check in with us?
Clifford Jeffrey.
Hi, Clifford. Thank you for joining.
How you doing?
Good. So we're just getting everything set up and logged in and ready to go. And hopefully we'll be able to function without any technical difficulties this afternoon.
Well, I've had my share already.
Oh, no. But you're here, so it must have worked out all right, okay?
Well, it did. The winds kind of disrupted everything here.
Yeah.
Oh,
yeah,
okay.
This morning, actually, our lights were out at night. This morning, I couldn't get on internet at all.
That's right.
Yeah, Deidre is still down on the internet, but she's
Okay.
joining us here.
Oh, okay.
So hopefully we'll be able to keep our time.
Light is on.
Huh?
This ring light is on. Let me unplug it.
Or just turn it off. Oh, that is a little better. There's just light coming in the door and everywhere else, but we can see you. So I could give you a screen if you want to put a special screen behind you.
Yeah, I mean, yeah.
Yeah.
Yeah, that would be good.
Okay, I'll be there.
And then you just take a screen. I think I get it on that chair. Okay, so go into here you go. Open that up a little bit. Okay. So go into setup a minute, I'll find it. There you go. Hope that won't dig in too hard. And then we're going to go into video. And we're going to choose a virtual background. Oh. Oh, you don't have any. You don't have any. Yeah. Well. Okay. All right. And it won't do any good. Let's see if it looks any better with just So yeah, I have a green screen. See if that helps. Nah, it doesn't help at all. Okay.
What about this lamp right here?
Try it.
How do I turn it on?
There's a switch right up at the top. I'll come get it. Uh-oh, Charlotte is on the line.
Oh, let me get it.
Okay, get out of this.
Hey, Charlotte. Are you-
My fault that Jim did. I didn't tell him. If you want him to call at 2:30.
2:45, it's 2:55 now, we begin at 3. Okay, can I see you on the screen?
He's on my phone. I have to get my computer open.
Oh, please open your computer, we need to see Jim.
I don't want you to see me.
Why?
I just don't.
Tell him we need him.
We actually need to
Do
see
you know how
your
to get
head
rid of
up.
that?
From your
You know how
head
to
up.
get rid of that screen?
Yeah.
Get rid of it. This isn't- that one light probably doesn't help.
Because our participants just need to see your face.
All right.
Okay,
I didn't comb my hair without.
all right.
Okay, and tell him we're live streaming.
We're live streaming and we are recording.
All right. I do it over here, so.
Okay, I see Barbara's joined us. And Brother Oliver, you able to do the door, the invite room? You're Brother Oliver. Oh, that looks okay, Deidre.
Okay,
Okay, hello there, Barbara and Madeline. Clifford is on the line, Deidre, and Brother Oliver. Okay, we are live streaming today, and I'm told by our technician that he sees us just fine. So everything is up and working. Our speaker is joining us in a few minutes. And Carl would ask that you record too, Brother Oliver. So if you'll hit record. Just as a backup. You're muted. Oliver, I see your lips moving. I don't hear word.
Yeah, okay.
Rose, I had to turn my sound off so
Should I
that
record?
there's no echo.
Should I record on the
Okay.
computer or should I
So
on the cloud?
when it's my turn to speak, I'll,
Okay, you'll unmute and I'll mute when it's time for you to speak.
okay,
Rose?
Huh?
that's
Should I
fine.
record on my computer or should I record on cloud?
On the cloud.
Okay. Okay, it's recording.
Okay.
Audrey is coming on.
Yep. Okay, great. I knew she'd be there. A little late for her.
Yeah. 2:59.
I forgot to send them all the reminder message I usually do the day before. It's been a strange week.
Yeah,
Charlotte, you can blur the background. Or not, it's your choice. What are you looking for? I can say it to you. Okay.
Get started. Can you guys hear me okay?
yeah, perfectly well. Sister Nelson, how are you?
I'm doing well, thank you.
Yeah, I didn't get to talk to you today.
No, we scooted out.
Yeah.
Liana says, you're gonna walk over there with the, she calls it Omarion. With the Omarion.
Okay, Charlotte. I have two Audrey Johnsons here. Okay.
We haven't started yet, right? Rose,
So,
are you gonna be at the church tomorrow?
who, me?
Rose.
Oh,
I'm gonna try, I don't know, we got a family outing tomorrow, and I don't know what time we're starting.
yeah, I'm thinking if we get there at 10, we should be out by 12.
Okay. Lavina,
Okay, very good.
Oh, hi.
Lavina,
I'm,
Mary Lynn is coming.
she
Oh,
asked me
that's
to be there
good.
with her. So I'll be there tomorrow with her.
Okay, in the interest of starting close to on time, I'm going to, open our meeting, and I'm saying welcome to everyone to our first monthly meeting of 2022. And I'm on a New Year's resolution, since we're still.
Can you come closer to your mic?
Yeah, we're in the same room.
That's
So I'm
good.
trying. Yeah, we're in the same room. I'm trying to. Deidre, can you
I
what do you
did.
call it? Mute?
Mhm.
And then when I mute, we're in the same room, so we can't both do it at the same time.
Okay. Okay.
Okay, so everybody, welcome to our first meeting of 2022. And what I was saying is, I hope everyone is still working on, and I know most people don't believe in resolutions, but to continue where we left off last year in making those health changes that we've been working on, and know that there's always a little room for improvement. And today we're starting our first monthly series for 2022 with our guest speakers series. And before we get started, I'd like to offer prayer. So let's bow our heads. Our Father, we thank you so much to have this opportunity to set aside time to think about the wonderful gift of health that you left us, and to learn more about how we can take care of ourselves and how that we can enhance where we are right now, no matter what condition we're in. We thank you for all your guidance. We thank you that you are the great healer and that you can heal us. In Jesus' name we pray. Amen.
Amen.
At this point, I'm going to turn it over to Deidre, and she is going to introduce our speaker for today.
Okay, it is my pleasure. Let me see, where's my sound? That sound.
We hear you.
Audio now, Christian.
You can start the video.
Huh?
Start the video down at the bottom of the screen.
She's trying to get it on now. So I'd have to do it without video.
His preference, of course, right?
Well, there's a mute button and there's a video button at the left-hand bottom screen. One second, please. Technical difficulties. Okay, well, I'm going to introduce the speaker. His name is James Holmes, Jr., MD. He grew up in Fresno, California, and he graduated from Fresno Adventist Academy. He went from there to Pacific Union College, where he completed the pre-physical therapy courses. He took physical therapy training at Loma Linda University, where he met his wife, Charlotte, who graduated a year after he returned, after his own graduation. And after practicing physical therapy for 11 years in Stockton, he returned to Loma Linda University to study medicine. After obtaining his medical degree, he returned to Stockton, where he has practiced medicine for over 40 years.
Wow.
Along with the practice of family medicine, he has held health programs for his church and for other churches. He has been a speaker at non-SDA churches. And he's been able to reach many people who, with our distinct truths in the area of health. His practice at this time in this area is in weight loss. He is the father of 2 children. His son is a radiation therapist at Loma Linda University. And his daughter is a physical therapist working in Lodi, California. His daughter, Beth, who we met at a previous Creation Health session, discussed depression with us. So because they're having difficulty getting the video started, I'm going to ask Jim to start without the video.
Okay, thanks. Can you hear me?
I can hear you. Can you get a little bit louder or closer to your speaker?
Can you hear me now?
Yeah, you sound a bit far away. So you all may have heard he and Charlotte referring to me as Trisha. That's what they're saying. Trisha, can you hear me? Which is also my name, which is my family prefers to call me Trisha. So am waiting for you, Jim. Charlotte? Charlotte? Rose, I'm gonna call him real quick to see, see what's happening.
Okay.
Why don't you mute for a minute and I'll talk about some of our other things we're going to be doing. While we're waiting.
Okay. Hello?
Need your mute, please. Thank you. Okay, so while we're waiting for them to work that out, we have a plan this year to, during the course of the year, cover a number of topics. We have the February 4th Sabbath or 4th Saturday afternoon of February, we're set up to talk about weight. And then starting in March, we'll give you the dates. We're going to do an 8 weeks weight control session. And the weight control session is titled, Are You Eating Enough to Lose Weight? And I think, we don't believe in diets. So, you're looking for something a bit different in how you will approach weight control. And we're excited about getting that workshop ready for you at that time. And during the rest of the year, we are looking to do a reversing diabetes seminar and then 12 weeks of wellness, depending on how many people would want to participate in that seminar. So we'll put word out so that people can log in and then let us know where their interest lies, and then we'll put the seminars on topic. Now, our plan for today was to have Dr. Holmes do a presentation. We'd like for you to put your questions in chat during the presentation, and then we'll answer the questions at the end of the discussion so that we might get through the information. And I'm certainly hoping they can get the live part on, because the technical part, we definitely need to hear him, even if we're unable to get the video part going. So, well, hello there. And it's just nice to see you guys that have joined. Did anybody have a good report from since last year of good outcomes or sticking with the program or anything like that? Anyone?
I have a good report. I kind of ran it at the last session, and
Right.
My hip is doing better. I've gone to physical therapy. I'm able to walk a hill, not all the time, and to go upstairs. So I'm doing better on that end. Plus, with my water thing and not snacking, I'm down 5 pounds. So
All right.
yes.
All right. Anybody else got good report?
I think don't forget to mention that among the things we are planning for the Sabbath afternoon program is going to be, one is going to be on breast cancer.
Yes.
That's coming up. Another one is going to be on prostate cancer as well, by urologist. So look forward to to those. And we also plan to have one on Alzheimer's as well. Those are 3 topics that we're working on for this year, coming up this year.
So we got lots to look forward to. Any other good reports?
Hi, everyone. It's Shayla. I bought myself a treadmill to eliminate all the excuses of walking. Like, oh, I'm going outside. I can't. There's dogs. I have come up with every excuse possible. So I bought me a treadmill. And a week full, I have used it. No excuses. Some days I'm like, oh, I don't know. And sometimes it's like 8 or 9 o'clock at night, but I just hop on it and go, and I walk an hour.
All right, all
I'm a
right.
week strong. I'm a week strong.
Okay, and it feels better every day, doesn't it?
Yes, it does. Last night I really pushed myself, and I'm really proud.
All right, keep up the good work.
Thank
And I
you.
trust everybody who has a plan is working that plan, and everybody who doesn't have a plan will get a plan. Because it's the only way you're going to get started is to have a plan. And then some of us need somebody to push us and somebody to be by us or whatever, but whatever you need, put it in, and we'll see what we can do to support. So they're still talking. I can hear them in the background working on this technical support issue. And maybe we'll have to have him just do the presentation by phone.
Yeah. Don't
Yes.
are they on Zoom?
Huh?
Isn't he on Zoom?
They're on with their iPad. They were earlier,
Oh, okay.
but we couldn't get the sound going. And now I don't know what we have. We'll know in a minute. Oh, okay. Wait a minute. You're muted. Can you unmute? There you go.
Hi, everybody. Good evening.
Good evening.
Hello there.
I've been greeting you since I didn't know you are not hearing me. I didn't know my phone was on mute. Sorry about that.
Right. Well, welcome on. I saw you waving, but your mute was on, and I knew you meant to say something. Welcome.
Thank you.
Okay, Charlotte, is he ready?
Let's see everybody's face.
Thank you.
Okay.
Yes, I can hear you. Hello.
Hello.
I can hear you. Are you on Zoom? I'm on the phone.
Oh, sorry.
That's all right.
Okay, so can everybody hear him?
No.
Jim,
Yes.
can I hear you?
Just say something. We haven't, yeah.
He's saying, can you hear me?
No.
No, not at all.
No, you're not on a Zoom call. Well, Charlotte is. Charlotte's phone. Charlotte, is that your phone number or your computer number?
No, this is the other Charlotte that always joins us.
Oh, Charlotte, you're not on at all.
She's not on at all.
He was on his phone earlier. Asked him if he can just dial in on his phone.
Just dial in on your phone. Jim, I'm going to hang up and you just dial in on your phone on Zoom, okay? Okay. Can you just do it over the phone? I can hear you on my phone, but you're not on Zoom. No, you're not on the Zoom call. I am going to give up. Hello? Yes, you're on the phone with me. So what do you try? Oh, he said don't give up. Sing and dance. Sing and dance.
I don't sing and dance. I don't sing and dance. I entertain. he dialing in?
Yeah, they're good. Are you dialing in too? Well, just get on the phone, whatever best way you can. Okay. Keep trying your Zoom.
Okay, she's coming on now.
Oh, you're coming on now.
Charlotte, yeah.
You're coming on.
We should have sound, Charlotte.
Unmute yourself. So I see Charlotte Brantley Holmes, and I just want to be able to hear you on the Zoom.
Just connecting audio now.
It's connecting now. Hold on, just wait a minute. Well, just try to get on.
Look at there. I think I see you all.
Okay.
Okay, so now click off the mute.
She's talking. She needs to click on the
No, you're on mute. Click off the mute. It's at the bottom of your screen.
She just went off.
We just lost you. Oh, you do see me? Well, that's good news.
They're on the screen. We just haven't got the audio yet.
Oh, you just don't have the audio yet.
Okay, connecting now. Okay, I hear there.
Okay, it's connecting.
Okay.
Go ahead and mute.
We see him, but he needs to unmute if it's connecting. But we can't hear him. So it's continued to connect.
Okay, now it's muted.
Excuse me, Elder Alabi.
Yes.
Okay, can you explain to me the problem that we're having?
No, I don't. Rose can explain to you. Now he needs to unmute. If he unmutes, then we can hear him. Okay.
How about
now?
now?
We go.
There you are. I think
we are.
we just heard you. Yes.
Okay.
Thank you
Well,
kindly.
Sorry about all of that, but we'll get started.
All righty.
Can you hear me?
Yes.
Yes.
Okay, we've got to be informal. When I'm talking, if there's anything you want to add or questions you want to ask me, you can just interrupt and we can do it at the time.
Okay.
I was asked to talk about lab tests today. And lab tests are very important in diagnosing diseases and also to follow up to see how you're doing with treatment. And most doctors are highly dependent on labs. We didn't have labs, I don't know what we would do. When I first started my practice a few years ago, I made a few house calls and I was very uncomfortable because I was trained on making diagnoses by using labs. So I didn't do that very often. I ended up having most of the patients come to my office if they could, If not, they probably have to go to the emergency room because I was not comfortable seeing them without having lab tests. Years ago, before we have the labs we had now, doctors had to make diagnoses by guessing. Doctors that suspected somebody might have diabetes person might come and say, I'm tired, I'm urinating a lot, I'm losing weight. And the doctor might think that the person might have diabetes, but they didn't have the lab test to do it like we have now. So years ago, doctors used to test for diabetes by what? You think you know? By tasting the urine. So if it was sweet, probably had diabetes. The sweeter it was, probably the blood sugar was probably higher. So that's how they diagnosed diabetes. In the 18th century, doctors used to feel that a lot of problems was caused by too much blood. They would do bleeding. Have you ever heard of bleeding?
No.
That's where they would nick a vein in the arm and draw blood off because they thought that the person had too much blood. Now, I don't know whether you know the story about George Washington. He was retired from presidency. He spent a long time working out in his yard and his garden. It was real cold. He came back with a very severe sore throat. So they called the doctors in and they didn't know what was wrong with him, but they did see his tonsils were very swollen. He could hardly breathe. So George Washington asked them to bleed him because that's what was going on in those days. And historically, they took off about 40% of his blood volume, which probably killed him. So when I look at what he did in those days, what they did in those days and what we do now, I think that what we would do is totally different because we have all the lab tests. We could do a blood test to see whether his blood count was probably high, and the bleeding, white blood cells fight disease. The bleeding took the blood plus the blood cells, the white blood cells, and that didn't help him. And of course, losing 40% of his blood, that probably killed him. So we would handle that totally different today because we have the lab tests, and we could get his blood count, we get his oxygen saturation, we could get chest x-ray if we needed it, and we would treat him according to what we saw in the lab tests. But they didn't have that. You can't blame them too much. That's all they knew. But I think that probably with today's medicine and the lab tests we have, he probably could have been saved and lived a little longer. We're talking about blood tests today, and the thing that's really in the forefront now is COVID. And you've heard about all the COVID tests for COVID. There are two tests that we have, the antigen test. Now, an antigen is anything that will stimulate the body to make antibodies. So the COVID virus is an antigen. The antigen test, you put a swab in your nose and get a sample, and you put it on a plate. And on that plate, you have antibodies that will detect the COVID virus if you have it. So there are two lines on the plate. One is the control line, which means anybody, if you don't have COVID, it's gonna change color. If you do have the virus, there's another line that will change color. So if you have two lines that have color, then you have the COVID infection. Now the viral test, the antigen test that is, might not be positive early on in the infection. You might have to have more virus than you have early on for the antigen test to be positive. So it might be negative. So you check it. If it is negative and you have symptoms, you probably should check it again in 3 days. Or if you really have symptoms, you probably should get the other test called the PCR test. The PCR detects some of the genetic material in the COVID virus. And the PCR test is more positive because in the lab, they magnify the material 100 to 200 times. So just a little amount of the COVID virus will be detected. So the PCR test is, if it's positive, you probably have COVID. If it's negative, you probably don't have it. So it's a very more sensitive test than antigen test. Antibody test is a test to check whether you've been vaccinated for COVID or whether you've had COVID. Because if you had it, the body will build up antibodies and it will show on the antibody test. Or if you've been vaccinated, your body will build up antibodies and the antibody test will be positive. If it's negative, you probably haven't had any contact with the COVID virus. Now, if you have a person who has been diagnosed with COVID, then you have to follow them, see whether your treatment is doing its job. Because if you follow them, one thing that COVID does, and you probably know, is affects the lung. And if you have been diagnosed with the positive COVID test, then what you should do, if you're not really sick, you can stay at home and just recuperate. If you have trouble breathing, then you probably should have your oxygen saturation tested. Oxygen saturation is the percent of hemoglobin on the red blood cells. Oxygen saturation is a percentage of the red blood cells that have oxygen. The normal range is 95 to 100. Now you can, if you're at home, just recuperating, and you start feeling short of breath, you probably want your oxygen saturation tested. Now you can buy a device down at the pharmacy called a pulse oximeter, and then they can check your own oxygen saturation at home. The normal range is 95 to 100. If it gets to be 90 or below, some people say 93 even, 90 or below, then you probably should go in and be checked by a doctor. Because if it's check you again and it's getting lower and lower, then you have to be treated. You might be treated with just oxygen in your nose at home. Send you home for a nasal cannula, put oxygen in your nose, through your nose, do that at home. Or if it gets low enough, you might have to be hospitalized. And most people are hospitalized because they have other difficulty breathing. When you're in the hospital, you might be put on what we call a BiPAP machine, which forces oxygen into your lung. If that doesn't work, then you have to probably be intubated. So when you go to the hospital, your oxygen saturation is constantly monitored. So they'll know what's going on. So if it keeps going down, you'd have to be treated accordingly. Also, you can get clotting studies because there's been blood clots associated with COVID, and they can do clotting studies to make sure your blood is not clotting. You can do CPR tests, which checks for inflammation, because inflammation is usually what causes the lungs to fail. There's a lot of fluid that accumulates in the lung, and people have trouble breathing, and the CPR was checked for the inflammation. So the lab tests are used to follow the progress of the patient, whether the patient's getting worse or whether they're getting better. And it's usually when the ventilation, the lungs get better, that's when they can get, discharged from the hospital. If it gets bad enough, you've heard of ECMO probably. That's where they use a heart lungs machine to oxygenate the blood and send it back to the heart and to the body. So you need these lab tests to check with a COVID infection to check and see how the patient is, whether they're improving or getting worse. So if we didn't have those lab tests to follow the patient, we'd be in pretty bad shape. Another test you hear about all the time on the TV, probably Cologuard test. A Cologuard test is a test for genetic material for cancer. Have you heard about that on the news? Can you hear me?
Mm-hmm.
I'm not getting any response. I'm just want to make sure you're hearing
Yes,
me.
we can hear you, Jim.
You're not reacting. You're not talking
Well,
back.
we're all on mute unless you ask us, and then
What's
we'll go
that?
off.
Oh, they're all muted?
Yeah, we're
Okay,
all muted.
Anybody with any questions?
I have a question. I haven't had COVID, but I was advised to get the monochrome antibody by a nurse calling to inform me that my grandchildren had COVID. And they asked me my age, and I told them, they said, well, you are entitled to get the monochrome antibody. And I didn't know what that was, so I called my doctor. She says, no. Short answer, no. So what is that?
Well, it's just monoclonal antibodies are just antibodies that are made up to treat the COVID virus. And it's they give it mainly to people who've had it. I'm not sure they give it to people to try to prevent it. And this is what your doctor said. I mean, if you have it, then it helps fight the disease. But if you don't have it, I'm not sure why you should take it.
Yeah, she said no.
Yeah.
Okay.
Anybody else? Okay, we'll keep going. Cologuard test, you hear it on the TV all the time about getting this test. They take a stool sample and they check it for DNA for cancer. And if it's positive, then you have to be checked further. Before the Cologuard test was done, you would just, if you had positive blood in your stool, you went to your doctor, you did a rectal exam, had positive blood in your stool, then he would say you need to get a colonoscopy to make sure you don't have cancer. And the Cologuard test checks for DNA for cancer. If that's a positive test, then you should go and get a colonoscopy. And that can check and see whether you have a tumor. People over 50 years of age should probably take the test, and people 45 or older with colon cancer in the family should probably take the test.
How often should we have a Cologuard test?
Well, probably once every, I don't think you need to do it once every year. Probably once every year wouldn't hurt, let's put it that way. If it's negative, then probably every 2 or 3 years. But once every year wouldn't hurt. Can never be too careful. Anything else?
Okay, so that test is what they send, like Kaiser sends it in the mail every year.
Yes.
And then you return it.
Right.
And okay, because I've had the colonoscopy with that test. So that Cologuard test takes the place of it unless it tests positive.
Cologuard test gives you an idea of whether you need a colonoscopy.
Oh, okay.
Yeah, because it tests for the genetic material of cancer. And if that's positive, then you need a colonoscopy. The colonoscopy is the gold standard for colon cancer.
Mm-hmm.
If you get the colonoscopy and there's nothing found, you probably okay.
Okay.
Is there
And you get
is there a reason why they say that once you are over 70, you really don't need colonoscopy?
Well, they figure if you're over 70, you've had colonoscopies on a regular basis, and you're probably going to be okay, you know. after 70, you're probably going to be okay. But it's not, one thing, it's not, the test is not without its complications. The older you get, probably the more you might have, reason you might have complications. But I don't think if you have some symptoms like blood in your stool and something, then of course you're going to have one done. If you have them on a regular basis up until age 70, probably going to be okay.
Okay.
I think that's the thinking on that, what GI doctors are thinking in that area. Anything else?
If you're not a member of Kaiser, can you get Cologuard at your pharmacy?
You can, yeah. If you don't, you have Kaiser?
No.
No, but your doctor can order it for you. If you're not at Kaiser, they can order the test for you. Yeah.
Okay, thank you.
Mhm. Anything else? Okay, let's go to about urinalysis. When you go to just get a regular appointment, your doctor might do a urinalysis, just a routine test. And if you have blood in your urine, of course, there might be a problem. Now, if you go and have a urinalysis because you're having some burning or with urination and everything, it's probably just a simple urinary tract infection. And if you have blood, they do urinalysis in the office, and you have blood in the urine as well as some bacteria, then they'll treat you with an antibiotic. And if it clears up, if the symptoms clear up, and check the urine again, if there's still blood, then it's not totally due to the infection. You might have blood coming from the kidney or from the bladder. So you have to be further tested. If you have positive blood in your stool, in your urine, I'm sorry, then you probably should be sent to a urologist and they can further check it out, see whether you have maybe a bladder cancer or something like that. So kidney stones can also cause blood in the urine, but people know that if they got a kidney stone, they know it because it's very painful. So you'll know that, and that can definitely cause blood in the urine. But you have back pain and very bad pain, it's probably a stone. So that should be checked out further. Let's talk a little bit about heart disease. Heart disease kills a lot of people, you know that. About 650,000 people a year will die of heart disease. That's about one person every 36 seconds. A lot of people have heart disease, don't know they have it. I don't know, sometimes you read obituaries and so-and-so died suddenly at home. It's usually probably 9 times out of 10, it's a heart attack. It's sudden. Had no idea they were sick, and all at once they're gone. Probably a heart attack. Unless heart attack or homicide, maybe sudden death. But if they die without any reason that you know of, it's probably a heart attack. Now, how do you test for possible heart disease? Of course, if you have any symptoms of heart disease, chest pain, shortness of breath, chest pain with exertion, maybe indigestion, to have certain signs, you probably should, things that you haven't had before. You know, it's a difference when you exert yourself a little bit, you get tired more easily. Or like I say, chest pain with exertion. Then it probably should be checked out. You see, I would have you go to your doctor and tell him about your symptoms. And if it's something that you know it's unusual with you, it might not be anything serious, but you know that this is something I haven't had, then you better have it checked out. A normal EKG in the office, doctor's office, does not really tell you if you have heart disease. Just a regular EKG. You go to the doctor, you got chest pain, I don't feel good. I get short of breath when I exert myself. He does an EKG and says, well, EKG is okay. That doesn't mean you don't have heart disease, because it has to be checked out further. Now, if you have these symptoms and you get an EKG and it's normal, if your doctor say, well, your EKG is normal, you're okay, well, you can't necessarily take that for the truth. You have to, I would suggest that you have him send you to a cardiologist to be checked out and make sure everything's okay. Now, how do you detect heart disease? If you come in and you've had high cholesterol and you have these symptoms, then perhaps you have something going on. Let's talk about cholesterol right now while we're on it, then we'll go back to other tests for heart disease. Cholesterol, the number under 200 is considered normal. You have two kinds of cholesterol. You have HDL and LDL. HDL is the good cholesterol. LDL is the bad cholesterol. HDL is good because it kind of clears the bad cholesterol from your system. The bad cholesterol, LDL, causes fat to build up in your blood vessels, and that can lead to a heart attack. A heart attack is caused by a major blood vessel supplying blood to the heart being clogged off. And the LDL can definitely lead to buildup of plaque in the arteries, and that can kill you. And as I said, you want your HDL to be high. Your total cholesterol should be 200 or below. Your HDL should be at least, let's go back and say it this way. There's a ratio between the total cholesterol and the HDL. If the total cholesterol is 200 and your HDL is 50, the ratio is 4. You want the ratio to be 4 or below. So you want to have a high cholesterol, a high HDL, and a low total cholesterol. It's 200, the total is 200. The high is 50, the ratio is 4. You want the ratio to be 4 or below. If it's higher than that, then it's not good. If you have a high cholesterol and a low HDL, you may have a ratio up to 6 or so, and that's not good.
Can you reverse your cholesterol if it tests bad?
Well, usually it's, some people have genetically elevated cholesterol, but if it's not, you're not genetically elevated, yes. High cholesterol due mainly to eating fatty foods, red meat, sausage, bacon, cheese, eggs. All those things are bad for cholesterol. And you should try to get how's that? Hello?
Oh, could you do that ratio again? Okay,
you want to have a high total cholesterol. A low total cholesterol.
Mm-hmm.
Just say if it's 200, and you want to have a high good cholesterol and a high HDL. So you take your total cholesterol and divide it by your HDL, and you get a ratio. It should be 4 or below.
Okay.
If you had a total cholesterol of 600 and an HDL of 50, then that's a ratio of 6, which is not good.
Okay.
The lower the ratio, the better.
Okay, because mine was 178 total cholesterol. Yeah.
Oh, that's not bad. That's good. What was your HDL,
Yeah, I got to figure out what my HDL is.
Yeah, but 178 is not high at all. So
you guys, I learned to tell the difference between the HDL and the LDL. We called it the happy.
Okay.
So if you take the happy cholesterol and had it over 50, that was the target they've asked us to look for.
Yeah.
Right. And a ratio of 4 or below. That's good.
Okay. Now I understand a little better because my HDL is 50 and my LDL is 150 or less.
LDL?
Yeah, my LDL.
That's pretty high.
Okay.
So, and what was your total cholesterol?
180 something.
And your HDL was what?
My HDL is 50.
Oh,
my HDL is 50.
LDL or HDL?
HDL.
HDL. Okay. HDL. Okay, that's good. That's a good ratio. Okay.
Another way to remember LDL is lousy.
Okay.
What's that?
Lousy
Oh,
for
lousy.
LDL.
Yeah. So the bad foods is what I mentioned: the red meat, sausage, bacon, eggs, stuff like that. You should try to eat the healthy fats, nuts and beans, carrots, avocado, things like that. Okay.
How often should you eat eggs?
How often?
Yeah.
Well, I don't eat them at all, so I'll say nothing. And you don't like that answer, I'm sure. I don't know. I mean, eggs, the yellow of the egg has the cholesterol. If you ate whites, I think you can eat as much as you want. But the yellow is where the problem is. How often? I don't know. So how often do you eat them?
Well, my wife had been, she cooks them about every morning.
Okay.
She boils them.
Boiled them, yeah. It doesn't matter whether they're boiled. Probably better boiled than fried, but it's the yolk in the egg that has the fat.
Okay.
Yeah, I know you can fry egg whites or not.
Ellen White says once a week.
Okay. Okay.
All right.
Excuse me, does it mean we should, excuse me, sir, does it mean we should not eat egg at all?
What's that?
Egg.
What about it?
We should not eat egg.
You'd be better off if you don't need eggs. You'd be better off if you didn't eat them, I would think, because of the fat. But I still can't say don't eat eggs. If you would you be better off? Probably would be.
Mm.
You don't need them. Let's put it that way. You don't need eggs to survive.
Wow.
So, Dr. Holmes, the other metric that's usually done with the cholesterol is the triglycerides.
Yeah.
What's that?
Yeah.
Triglycerides is another fat in the blood, And let's see, hold on a second. I have some normals here. Yeah, it's another fat in the blood, and it can, it's not as bad as cholesterol as far as causing heart disease, but it can if your triglycerides are too high. And the normal range should be 70, under 150.
So, Dr. Holmes, can you talk a little bit about creatine levels or creatinine?
Creatinine, yeah. We'll get to that. The kidney function test. Yeah, we'll get to that.
All right.
Let's go back to checks for heart disease. Like I say, just the EKG doesn't tell you much. Cholesterol levels, if they're high, there's a test called C-reactive protein. That's a CRP for short. That checks for inflammation in the body. If a person has says you're having heart symptoms, the doctor does a CRP, that might indicate you have some heart disease going on. So that's another sort of a test you get to screen for heart disease. Now the EKG, regular EKG, is not really diagnostic heart disease. It just tells you the heart's beating, and it tells you what's beating in the regular rate or not. It doesn't mean you don't have heart disease. Exercise stress test is where you get on a treadmill and stress your heart. And then that tells you if your heart functions okay on the treadmill, you're probably okay. You don't have any irregular beats. If your EKG doesn't change, there are certain changes on the EKG with a stress test that can indicate that you have a heart disease. So the stress test is more something that you could do to see whether you have heart disease. Coronary angiogram, that's the gold standard. Is when they put a dye in your heart blood vessels, and if there's any blockages, it will show up on the angiogram. If you have an angiogram and it's totally clear, you probably don't have heart disease. And then there are CT scans you can get to. It will show the outline of the coronary arteries to see whether there's any plaque buildup in the artery. So those are good tests to check whether you have heart disease. Now, one test that most doctors are doing now in the emergency room, if you come in with chest pain and you say, I have this chest pain and short of breath, I've been sweating and all, and suspect a heart attack, they get a test called troponin. Most ER doctors will do that now. Troponin is if the heart muscle is damaged, it will release a chemical called troponin. And troponin is an indication that the heart muscle has been damaged and you're probably having a heart attack. This test has been around for 5 or 6 years. It hasn't been around that long, but doctors use it a lot to detect heart attack. I have one little story I'd like to tell. I had a patient came into my office a few years ago when I was practicing. And she just said, I feel tired a lot. Feel tired. I said, well, having any other symptoms? Shortness of breath, chest pain, anything like that? I said, no, she said, no, I just feel tired. So I said, well, let's get some blood tests. If somebody comes in tired, well, you want to check the blood count, maybe sure they're not anemic. You want to check for anemia. And the thing that you don't think about, most people don't think about, of course, check the thyroid and stuff like that, is heart problems. And so I was thinking, I said, you have chest pain, neck pain, back pain? No, I'm just tired. So I know women don't always present with the typical symptoms of chest pain and arm pain, neck pain, shortness of breath. She had none of those things. But I said, I want to get some tests. I ordered the CBC, which check for blood count, hemoglobin, ordered the thyroid test. And I said, I'm going to order troponin on this lady. She's tired. She's a woman. Women don't always present as men, so I ordered a troponin, stat, all these tests, stat. And about an hour later, I got a call from the lab, says the troponin is high. I said, my, didn't suspect that, but I got it. So I said, well, I called the lady, and what was frightening about it, I couldn't reach her. She didn't answer her phone. So I said, man, I hope she didn't go home and have a heart attack. She seemed like she's having a heart attack. I hope she didn't go home and die. So I called and called, no answer. I got her address and plugged it into my GPS. Going to go to her house, and I called again just before I left, and she answered the phone, which was a great relief. And I said, who's there with you? She said, my daughter's here. I said, we'll have her take you to the hospital now. And when you get to the emergency room, tell them your doctor thinks you're having a heart attack, and they'll get you right in. So he took her there, and he took her right back, and she was having a heart attack. So that troponin test is very, very important. And like I said, most ER doctors order it when people come in with chest pain, even though they, okay. Any questions on heart problems?
I have a question. I have some people in my family and friends that have congestive heart failure. was their diagnosis, and they're relatively young, sort of middle age, but they both died of congestive heart failure, and they were both diagnosed. What could have been done to save them, or what is congestive heart failure?
Did they have previous heart attacks?
No.
No.
Not that I know of. I don't know.
Yeah. Well, congestive heart failure is just when the heart is not beating as forcefully as it should to force the blood around the body. And the heart gets big, the muscle gets flabby, and sooner or later, you know, it gives out. Now, what causes it? Most of the time is caused by people who had heart attacks. And a heart attack is when the blood vessel gets clogged up and the heart muscle doesn't get blood, and it's damaged and it gets weaker. And most people maybe have had heart attacks. There is a situation we call cardiomyopathy. For some reason, people get a virus can affect the heart muscle. And it's called cardiomyopathy, and the muscle gets weaker and weaker, like I said, and pretty soon people can't survive. So, but usually congestive heart failure is due to people with heart disease. But like I say, the cardiomyopathy can be due to a viral infection of some sort. So, but that's, how old were they when they died?
About between 40 and 60.
Yeah, that's pretty young. It's very young.
Yeah.
Yeah. Huh. I don't know. Maybe who was it? Were they related?
Well, yeah, two of them were related. They weren't family members, but they were brother and sister. And they died within a year of each other.
I don't know. Maybe there was some genetic component to that. I don't know.
Okay.
But that's pretty young. Very young.
How likely is permanent heart damage after an acute heart attack?
Permanent? Well, it depends on how bad it was. I mean, if you have a major vessel that's been plugged up and you get a lot of the heart muscle has been damaged, then you might have more of a tendency to have congestive heart failure. So a lot of people they have heart attacks, but they get better totally, you know. So you can't say, I think after you get the heart attack, then you should get studies like echocardiogram and really tell you a lot about how the heart is functioning. So you just have to follow the patient after the heart attack and see how they're doing. A lot of people do quite well. But they start having symptoms of congestive heart failure, which would be shortness of breath with exertion, maybe some swelling in the legs, trouble breathing, lying flat. All these are symptoms of congestive heart failure. So you just have to follow the individual patient to see how they're going to do.
Excuse me, sir. Oh, I have a question. Is this a heart disease that normally causes sudden raised blood pressure very high without chest pain?
I didn't quite understand you.
Somebody who doesn't have chest pain, but normally have rise high blood pressure without chest pain. Is it a heart disease that causes that?
Don't have, you say they don't have chest pain?
Yeah, yes, sir. But they suddenly have a high blood pressure suddenly without chest pain. Does the person has a heart disease? Such a person has a heart disease?
Just because no chest pain and high blood pressure?
An individual without chest pain, sir. Suddenly have high blood pressure suddenly, without experiencing any chest pain. I just want to find out whether such a person is suffering from a heart disease.
Well, you don't know for sure. High blood pressure in itself does not tell you the person has heart disease. A lot of people with high blood pressure don't have heart disease.
Okay,
So just
exactly.
because
That's
you have high blood pressure doesn't mean you have heart disease.
all right. That's what I want to.
Yeah.
Thank you.
But isn't it the fact that high blood pressure can create a stroke?
Definitely, yes.
Okay.
Yes.
Yeah,
I was
high
going
blood
to ask.
pressure.
Yeah, I was going to ask the question about many people go around and they discover they say you've had a silent heart attack.
Uh-huh.
Because they oftentimes during some kind of analysis will see some damage to the heart. So they say it's silent because you didn't even know you had it.
Well, yeah. Well, that's probably, it's unusual. I mean, if you have a heart attack, how do you determine whether a person has a heart attack or not? I think you can, if a person does not have symptoms, it's hard to know how they would come up to with the diagnosis of them having a heart attack.
I do agree with
if
that
they've never
statement.
had any. Yeah, I don't know. A lot of people are in denial. Okay, a lot of people have symptoms and they don't want to have it checked out because they might have a heart attack. They might find something. And a lot of these people that die suddenly, and I'll do something here. Can you hear me?
Yes.
Okay, a lot of people that die suddenly, and they say, well, the family says, I didn't know they had anything going on. They never complained of anything. It might be because they never owned up to it, They don't want to find out. And then all at once something happens. But if people have symptoms and they're checked out thoroughly and they find the problem, a lot of it can be eliminated and fixed. So, like I say, sudden cardiac death is something that I had a patient came to me. He was complaining of a chest discomfort with exertion. Young man, young black fellow, he was about 35, chest pain with exertion. And I said, well, probably have a heart condition, but I don't know. He's probably one of these persons in denial. I gave him some nitroglycerin. So, which if you have chest pain with exertion, the nitroglycerin will tend to open up your blood vessels and take the pain away. And I referred him to a cardiologist. And I got a call early one morning. This is the coroner's office. I'm out at this patient's home where he's deceased. He has a bottle of nitroglycerin with his name on it. And I usually always send people to cardiologists if they have a problem like that. And I forgot that. Did I send this guy to a cardiologist or not? About 3 o'clock in the morning. So I was kind of panicky, really. Get a coroner's call. So I get up and run down to my office and check his records. And I had sent him to the cardiologist. But I called the cardiologist the next day and I said, I sent this guy over to you and he died. He said, yeah, I talked to him a few days ago and I gave him an appointment, but he said he had to have some business to take care of. So he didn't come in for the cardiology evaluation. So I don't know whether he was in denial or not, but anyway, he's a young guy and he could have probably still be alive if he kept the appointment. So, like I say, heart disease kills a lot of people every year. So if you have any symptoms that you think are unusual for you, have it checked out and insist on having a complete workup for it. Okay, let's go to, do we have a certain amount of time, Tricia?
We have about 30 minutes.
Okay, well, we got enough time. Let's go to diabetes. Diabetes is very common, as you know. Symptoms of diabetes: fatigue, thirst, blurred vision, frequent urination, weight loss. Blood sugars now, like I say before, we had all the labs, and now they check for diabetes by tasting the urine. But now we have all the tests. We can get all the tests we want for diabetes. Your blood sugar normal level is about 100. If you fasted overnight, blood sugar taken, if it's 100, it's probably diabetic. But there's a thing called pre-diabetes. Before you get full diabetes, a fasting blood sugar of 100 to 125 it's pre-diabetes, and fasting blood sugar over 125 is diabetes. And also you hear a lot about now people on advertising, my A1C is this, my A1C is that. A1C is a blood test to your red blood cells will pick up hemoglobin, and it's called glycated hemoglobin, and it's called glycohemoglobin. And if your glycohemoglobin, there are numbers there. If it's 5.6, you're probably normal. 5.7 to 6.4 is pre-diabetes, and over 6.5 is diabetic. Now, the hemoglobin A1C only gives you what's going on at that particular time. Because I said hemoglobin A1C is caused by hemoglobin attaching to the red blood cells. The red blood cells live about 3 months. So the hemoglobin A1C is your blood sugar average over the past 3 months. It doesn't tell you where it is at that moment. Now, if you consistently get a low hemoglobin A1C, which probably means your blood sugar is being controlled pretty good. But if it's up and down, then your blood sugar is going up and down. So A1C, hello?
I'm sorry, may I ask a question?
Sure.
Did you say that if your A1C is 6.5, that you're diabetic?
Yes. 6.5 or above. 5.7, 6.4 is a pre-diabetes. 5.6 is normal. So it's just a way of following how well you're controlling your blood sugar. And as you know, elevated blood sugar over periods of time can cause a lot of different problems. Cause eye problems, some people go blind because it messes with the circulation in your blood vessels, and can lead to heart disease, and can lead to amputations because the blood vessels are damaged and don't get enough blood to your extremities, and you can have amputations, blindness, heart disease, all those things. So the best thing to do is try to control your diabetes.
Jim, I try to practice intermittent fasting, and it seems to control diabetes levels.
Okay. If that's controlling you, Tricia, I would say continue. As long as you're getting proper nutrition. You on medication?
Yeah, I'm prescribed medication. But I still try to do it without.
Okay, all right. So sometimes you don't take it, huh?
That's right.
Okay. Let's go to thyroid function. No question. Any other questions on diabetes? Okay, let's go to thyroid function. Thyroid hormone is kind of regulates the metabolism of the body. And a lot of thyroid, if you're low thyroid, can be mainly caused by fatigue, thinning of the hair, sometimes constipation, people getting cold, cold intolerance. All these things can be due to a low thyroid. And usually tested for thyroid with a thyroid stimulating hormone. That's the hormone that's produced by the pituitary gland. If the thyroid is sluggish, not putting out enough hormone, the thyroid stimulating hormone would be elevated. So that'll tell you that the pituitary is trying to produce more stimulation to the thyroid to produce more hormone. So the first, if you're going to test for thyroid test, the test you mainly get is a TSH. TSH is high, showing you have low thyroid hormone. Then you check for the thyroid hormone. And if that's low, then thyroid is failing probably. So then you might have to take thyroid medication to get the hormone up to the level it should be. Questions on that?
I know that in my family, thyroid is genetic problems with thyroid. My mother had her thyroid removed. My aunt suffered depression and thyroid problems and had to take thyroxine or thyroid medication. So
Okay.
seems to run through the family.
Yeah, I think sometimes it is genetic. A lot of people that I have a weight loss program, a lot of people say, I gotta check my thyroid. It's usually not the thyroid though. Probably more of a salivary thing than thyroid, salivary gland problem. Okay, let's go. What else we have here? Oh, somebody asked about creatinine. Yeah. Very good. Got my notes here. Okay, a creatinine, if you see have a lab test and you see a chemistry panel, it has a GFR, it's the glomerular filtration rate. That's how the kidneys filter the blood by removing waste products. And the filtration rates tells you how fast the kidney is doing this. And you want it to be a certain number. Below that number, the kidney function is probably not doing what it should be. We want the glomerular filtration rate to be 60 or below. If it gets to be 60 or below, then you might be developing some kidney problem. Now, creatinine, it's a waste product from the digestion of dietary protein. It's a waste product from the digestion of dietary protein, and the normal breakdown of muscle tissue. Muscle tissue is breaking down all the time, and it creates this creatinine. The creatinine level builds up. That means your kidney's not filtering or getting out the waste as fast as it should, and you might be getting some kidney function problems. There's a normal range of 74.74 to 1.35 milliliters per deciliter. A deciliter is a tenth of a liter. So this tells you if your creatinine is building up, it means your kidney function is probably not functioning as well as it should be. And then you probably should see a nephrologist, which is a kidney specialist. Does that answer your question?
Yeah, that was good. Okay. I needed a better understanding of it. But it seemed that in the case of some of my family members, I don't know, it sounded as if they were kind of utilizing that test kind of as an indicator for cancer, which I didn't quite understand how they were doing that. That's why I asked. It just didn't make sense to me.
No, unless you have kidney cancer destroying your kidney, creatinine would probably build up, but just creatinine being built up due to a cancer problem, I don't think so.
Yeah, because they did send,
unless it's of the kidney, because the kidney that tells how well your kidney's functioning.
All right, because as it went up, they did send the person to see an oncologist, which I was like, I'm not quite getting this. And the oncologist came back with, they're fine.
Yeah,
so
I don't.
Doctor misdiagnosis or not understanding the test or something.
Well, I don't know. If I have a patient with a high creatinine, I would send it to an oncologist right off, unless we did a scan or something and saw something on the kidney, maybe tumor or something. But oncologist, I don't know. I don't understand that one.
I
And
didn't
the
either.
oncologist said it was okay, right?
Yeah, I can read, and I was like, this doesn't make sense. I don't understand why we're here. And I could never really get an understanding from them on that. Even, well, oncologists thought it was ridiculous that they were there because they said, no, this has nothing to do with that. And I'm like, so why would doctors send her here for that specific reason? So it was a little weird.
Yeah,
okay,
I don't understand that.
All right.
I went to the, I changed doctors a few years ago, and my creatinine was, I don't know, I guess it was 0.85 or something like that. And I'm not sure if that's what it was when she sent me back for another test, but she was concerned. And then she came back and said that in African Americans, it's something. I wasn't following her in terms of what's the difference between non-African Americans and African Americans on that one.
Well, it wasn't so much the creatinine, it's probably GFR, the glomerular filtration rate. They seem to, I think there's some question about that because they seem to think that the GFR in African Americans should probably be higher because for the answer I've gotten there, that muscle mass in African Americans are more than Caucasians. And like I say, creatinine is a product from the breakdown of muscle mass, and that might be it. I don't know. But as long as it's in the normal range, I don't think you should be concerned about it. Was your creatinine high or what?
I don't think so.
Yeah.
So I'm in the same case. Mine wasn't high, but you see on my results from Kaiser, they say African American, and I was like, so what's the difference here?
Well, that's the thing.
My doctor could not give me an understanding, and I was like, I don't know if I can trust you because you don't seem to know what you're doing.
All the lab tests come back with African American on there, and that's the reason, because they think it might be a little higher because of the muscle mass thing. That's the only reason I've known.
Well, if they saw me, yes, I got a lot of muscle mass. Right.
I have a quick question for you about the creatinine. So you were saying if it's on the low end, that's probably indication of your kidneys not functioning well. Am I correct on that?
No, if it's on the high end.
Oh, on the high end. Okay, perfect. Thank you.
Jim, were there any other tests that you were going to go through? Because
One more test.
Okay, one more test. And then I have
prostate. We'll just talk about prostate. This man you do.
Prostate. Yes, that's a good one.
Yeah. Okay, the PSA is a test for prostate. You rule out prostate cancer. You want your PSA to be 0 to 4. That's in the normal range. Anything greater than 4 might mean prostate cancer. It doesn't necessarily mean it because you can have an elevated PSA if you got an enlarged prostate or if you got a prostate infection. Prostatitis can cause a elevated prostate antigen PSA. So if you don't have any of these things, then you need to go to a urologist and they'll do a biopsy and take some of the prostate tissue and check it out and see whether you have cancer. There's a score they call it a Gleason score. The pathologist, the person who looks at the tissue under a microscope, will give it certain grades. A grade in 2 levels, 2 areas, and they'll add those up. And if it's above a certain amount, then you probably have prostate cancer. So what do you do for it? If you're 80 years old or older, you don't do anything. If you're a young man, then you probably should have a treatment for it. You have radiation treatment. My son is a radiation therapist down at Loma Linda Medical Center, and he treats prostate cancer with the Proton machine.
Yes, Proton, best way.
Yeah, and the Proton machine directs the radiation directly to the area where you have the cancer. Whereas other radiation can affect other parts of the area, like the rectum and all. People might end up getting problems with rectal problems and things like that. The proton seems to be better because it zeroes the beam right on the cancer. And it seems to be quite effective. Or you can have a prostate cancer removal, which comes up with a lot of complications. Like,
Jim, isn't prostate cancer higher in African American males?
yes, it is.
And I have a couple of friends who had it, and one of them told me that the doctor advised him if he got surgery, he was going to lose all sexual function. That's
a problem? Now, there are some surgeons, I mean, that are in certain areas doing prostate cancer surgery, and they're not destroying the nerves that have to do with sexual function. And matter of fact, I think I don't want to say his name because I don't like him anymore. Ben Carson. Well, he had prostate cancer. I think he had the nerve sparing surgery. I guess it works okay. But yeah, if you don't have regular prostate surgeon who's not specialized in that area, you probably would lose a sexual function. And you might lose some bowel function too. So the best thing is radiation. It's better than surgery.
So I have I guess it's a comment. I heard that they are now using proton radiation to treat brain tumors. Is this correct?
Probably, yeah. Yeah, they are. Proton's treating a lot of eye tumors.
Yes.
Yeah, because they can zero the beam in pretty directly, to where they want it to go.
And didn't Loma Linda had a lot to do with that?
Loma Linda started it.
Yeah.
Yeah.
Yes.
That was the first proton machine at Loma Linda.
Yes. I remember reading about that. And I sent several gentlemen I know down, they actually paid outside of their medical plan to go to Loma Linda to get proton treatment for their prostate.
Yeah.
And they're both still here.
Good.
Man,
yeah, they're the first. They started there, and I think they have a number of places now.
Yes.
But Loma Linda was the first place.
Yes.
All right, Trisha.
Okay, yes. Jim, that leads me to my last question is, you're aware we have a health van. We take it to churches and we take it to the lake and different events. And we have a couple of nurses and we do diabetes and high blood pressure checks. That same health van was used by Healthy Oakland when it was a brand new health van. And I remember we were doing prostate tests because see what we do with our testing on board the health van is to refer them to the doctor or give them a soft referral to a clinic. And I was wondering, do you know of any other testing that we could do since we have a captive audience when people stop by to aid in their diagnosis or health?
So when you say prostate test, you have people doing rectal exams?
No.
Blood test?
There was some type of test. I don't know if it was a blood test or not, but I don't know. And besides, that was about 15 years ago. So I don't know what kind of test they do today.
Yeah, I don't know what kind of prostate test you would do on a van.
Okay. Well, maybe it was prostate awareness for African Americans.
Oh yeah, probably that. Yeah,
that's probably it. But are there any other tests that you could recommend that we do, or are we kind of stuck with our limited?
So what were you doing? Did you do? You could have the glucometer to check for blood sugars.
Yes, we have two nurses that do that.
And you can have a probably check for your analysis. You have these dipsticks to check the urine for sugar and protein.
Yeah, no, we didn't want to get involved in that.
Yeah. Yeah,
we do a finger stick. Mm-hmm.
Yeah, right. You can do that. I don't know what else you can do.
Okay.
Is the PSA test a blood test? How's that test taken?
It's a blood test.
It is a blood test. Okay.
Right. Uh-huh.
Is the biopsy somewhat routine for detecting or diagnosing prostate cancer?
No, the biopsy is done only if you have an elevated PSA.
Uh-huh. And does that put somebody at risk of being incapacitated? Because you mentioned radiation was better than surgery.
Well, I don't understand your question.
I was wondering if biopsy, one of my relatives is going to have a biopsy for prostate. Right.
Okay.
And I was wondering, and he's in another state, and I was wondering if that is pretty routine for somebody who has an elevated, is a biopsy pretty routine for somebody? Okay.
It's routine. If somebody has an elevated PSA, it's routine to get a biopsy.
Okay.
Sure. Okay, is that about it?
I have one question I want to ask you, if you wouldn't mind. Testosterone and cancer. Can you just speak on that just for a moment, please?
Testosterone and cancer?
Yes. Yes. Go ahead.
I think elevated testosterone. I think if people are probably have prostate cancer, of course they shouldn't take testosterone, because testosterone can stimulate the cancer growth. And people with cancer, prostate cancer, they probably sometimes put you on female hormone type thing to kind of stop the growth of the cancer. So testosterone is not good for prostate cancer. Now, can you take it? If you don't have prostate cancer, is there a problem taking testosterone? As far as I know, I don't think so.
Okay. If you previously had cancer, it's okay to take testosterone.
If you previously had prostate cancer?
No, cancer.
Oh, cancer is just general cancer. I would think so. I don't have any reason to believe it wouldn't be okay.
Okay.
But with the prostate, it's probably not good.
Okay.
Well, Rose?
All right. If you can mute, I'll let you.
Okay, if there are no other questions for Dr. Holmes, we can end this session. I'd like to, first of all, thank you, Dr. Holmes, for your presentation this afternoon and your willingness to help us with the monthly meetings. We definitely appreciate it. And as we will be having next month, the discussion on weight control, we'll be looking forward to that. Does anyone have any last questions for the meeting today?
I don't have a question, but a comment. Just to express our sincere gratitude, Dr. Holmes. I've really learned a lot this afternoon, and we really appreciate, your coming to us and giving us this information. It's a wealth of information, and I'm just hoping and praying that more people will join, so that because this information is very vital, very important.
More people are here.
People want to be heard. Thank you very much.
Yeah. Now the next meeting is
right
the fourth Saturday.
It'll be the fourth Saturday in February.
Yeah.
And we'll put out information. It'll be on the same link. And it'll be at the same time, 3 to 4:30.
You really blessed
and
me
we
today.
are live streaming it through the church live stream.
Excuse me, doctor.
Yeah.
Yeah. So possibility there's dementia in the family. Are there any particular tests that you can think of to check to see if you personally have a possibility of dementia coming?
I don't know of any specific test.
Okay.
If there was, I'd take it myself.
Well, don't they? I understand there is a test that they can perform to see if you have excessive plaque on the brain. I know Kaiser refuses to do it. But some hospitals say that, or doctors will do this scan. I don't know if it's a CAT scan or what, but they can see if you have a high levels of plaque. Because dementia and Alzheimer's are are kind of impacted by high levels of tau plaque, and there's another plaque that builds up. So there is an X-ray or something that they can do to tell you how your levels are.
Yeah, well, I'm not familiar with that, but there probably is something out there. But,
well, we do have somebody, I think, that's going to speak on that sooner or later. So,
oh yeah, we'll get to that.
They need to come on with it. That's something that Alzheimer's is almost killing as many people as cancer. Alzheimer's, I think it's taking people out of here left and right.
So that's one of the topics.
Do different things. Yeah, so it's very important in our community to understand it.
Right. That's one of the topics we'll definitely put on the list.
Yes.
A lot of us are running from that. Our families, we used to be the younger people in the family, and now the older people have gone and they all had it, and here we are. So we need to pay particular attention. But, like everything that we're doing, the best that you can do is stay healthy yourself, eat healthy, get plenty of exercise, drink water, get good rest, follow the 8 laws of health, and trust God. And do the best that you can do. And then what comes after that, you're out of control of. So what we are doing in our group is just trying to do the best that we can with the information that we have. So I appreciate all of you for joining today. We are at the end of our allotted time. Dr. Holmes, again, thank you. All of you that attended today, thank you. Those that are listening on the web, we really appreciate this subject today, and we know how vital and important it is to us. All right, we'd like to close with prayer. So if you'll bow your heads, we'll close with prayer. Pastor, you want to say a word? I was happy to see you come in.
Well, thank you. Sorry, I'm a little late, but I think you guys know why I'm a little late. But thank you, Dr. Holmes, for being here with us and giving this health seminar this afternoon. So with that, let's have a word of prayer as we close out.
Thank you.
Heavenly Father, we just want to thank you for the opportunity to learn more about health. Because Father, no matter what we do, if we don't have good health, Lord, we cannot be effective in our use by you. And so, Father, we're asking, Lord, that you would bless what we've learned and help us to apply, Father, not just make it informational, but help, Father, to make it be transformational for us as well. So we just want to thank you for who you are. Thank you for using Dr. Holmes, and for all of those that were able to attend via Zoom or via YouTube. We ask, Lord, that you'll bless each family that is represented here and those that may watch this video later on in the future. We ask your blessings in Jesus' name. Amen.
Amen. Goodbye, everybody. Thank you.
Thank you all so much.
Goodbye.
Be safe.